It is now my pleasure and honor to introduce you all to our second keynote speaker of the morning, Donna Cryer. Donna is founder and chief executive officer of the Global Liver Institute, GLI, the premier patient-driven liver health nonprofit operating with offices and partnerships across 5 continents. Moved by her own experience as a 28-year-old liver transplant recipient, Donna serves as a fierce advocate for the transformative potential of patient engagement and health policy, research, data, and system design. Her expertise and effectiveness in advancing the voice of patients in defining and designing equitable healthcare has been recognized by the United States Congress and the White House. In 2021, she received both the Global Genes Rare Champions of Hope Founders Award and the American Association for the Study of Liver Distinguished Advocacy Service Award. She has been named one of the top Blacks in healthcare by the Milken Institute at the George Washington University School of Public Health and blackdoctors.org, one of the top 10 patients who make an impact by health 2.0, and one of Pharma Voice's 100 most inspiring people. I am humbled to be introducing her this morning. Donna received her undergraduate degree from Harvard and a JD from Georgetown University Law Center. Please join me in welcoming Donna to the podium.
Thank you so much. I am going to do something that very few Harvard graduates do. I'm going to admit that I asked, what can I contribute to this meeting? My team is very strict with my time, and so the title of this meeting did not contain the words hepatology, liver cancer, NASH, or even hepatitis. And so they were like, why are we supposed to let you out of your office? First of all, I get the opportunity to thank the wonderful Dr. Dora Hughes for her candor and her allyship, her leadership at CMS. I get hopefully to prepare your hearts and minds for the IVI Equity Initiative report. But I think the people in this room and listening are sort of already the converted. If you are interested in value and methods and equity and putting them all in the same sentence together, you are already a very unique group of people. So perhaps I thought you just needed someone to be ever so slightly provocative and energetic on the first Monday morning after daylight savings time and after the Oscars last night. So I'll try to bring that energy to the room. I have been known from time to time to be provocative. My purpose, however, has always made time for discussions of value. They've always made time for the unique and challenging conversations that we've been able to have here at IVI. And I'm very honored to have been on the founding board. But I have a special privilege because only my liver identifies as a 28-year-old. The rest of me is a little older. And so I have had the privilege of seeing the intersecting arcs of advocacy from the patient engagement movement and the various civil rights and health equity movements. We've called them disparities. We've called them a lot of things, but we've come to this moment where, for me, they've always lived together. It's very exciting that as conversations in Washington, D.C. and across this country and around the world, they're now coming to be recognized as the same conversation. And so perhaps in our brief time together this morning, my words really are not so much for you, but for the other patient advocates who may not feel that they belong in this conversation and maybe having trouble navigating between these movements and these conversations. And so we're gonna see how much patient and technology. Can you advance them, Judy? Thank you. Okay. The title I've been given is Patient-Driven Value Seeds of Change. We will address that metaphor as well, but I'm gonna let you keep advancing, Judy. Oh, good, see? Let me just say right there, when one thing doesn't work for you, don't keep trying to make it work. Pick up something different, make that work. So I'd like to have Judy totally run the slides. And I wanted to just give an overview that I'll be discussing methods, metaphors, and mantras. So first we want to demystify methods. So whether you're reading from an Oxford Dictionary or Merriam-Webster, you see that the definition for methods, contrary to what we've all been told, is rather a simple, straightforward thing. It's a procedure or process for obtaining an object. We have been persuaded that methods is this mysterious, complex field full of formulas and, dare I say it as a political science concentrator, math. There's math involved and models. But really, what this is just a representation of what we want to accomplish. Surely all of us can be part in that conversation. Methods and methodology and conferences prior to this have used that language, have used that complexity to keep people out. And it has been used to hide that we have not been trying to solve for the right object. I was so excited that Dr. Hughes pointed to the new CMMI vision that a healthcare system that achieves equitable outcomes through high quality, affordable, person-centered care. That is not what they were solving for before. That is not what they were aiming to do. That was not the object of the method. So now we have an opportunity to make it so. Can we have the next slide? Fantastic. So since I was given this challenge of this wonderful title of planting seeds for change, and I'm never one to back down from a challenge, I thought indeed that this we could use this metaphor of planting seeds for a discussion of methods and health equity, because indeed we have planted bad seeds, and so we have yielded bad fruit. I would say perhaps, since this is an equity conference, we have sometimes yielded strange fruit because people have died from what we have failed to do. And in fact, what we have designed the system to do. This also might be a gardening, a planting seed metaphor as we approach spring here in Washington, D.C., although the weather seems to do everything today to deny it. That our current framework, our current fragmented ways, our current methods do not, in fact, measure holistic healthcare or health outcomes, that whole person care that we talked about in what is now the vision. Think about it this way. If you did traditional health technology assessment in a garden, you might say for this plant, let's try all sun. Well, this didn't thrive. We gave it sunshine for all the time, 24 hours a day. Somehow it didn't survive. Sun must not work. All right, well, let's do another one. Let's do a totally isolated, siloed technology assessment. This technology is water. Let's pour water for 24 hours on this plant. Water it for weeks, water it. We just want to water it. Well, this water thing must not work. Maybe it's the soil. Let's just test soil in isolation to anything else. Well, clearly, this experiment proved, this very rigorous test proved that soil is not the thing. Soil doesn't work. I don't even think plants need soil. And so that's how we traditionally look at health technology assessment. We look at a drug or a device or a surgery in isolation. And we ask if that alone has value. Because it may not, I would submit that perhaps our experiments are the things that are wrong. Because having been a patient for a very long time, I have never gotten a drug or a device or a surgery or a doctor's visit in isolation. And so I would think that perhaps if we use perhaps what's called mixed methods or just new thinking, maybe let's call it what people do, common sense, that you might do an experiment that uses a little bit of sun, a little bit of water in some nice soil and see what happens in a time frame that works for what we're trying to grow. And finally, I will deploy this metaphor of planting seeds and nurturing things to again point out that this field has until this moment maintained that only certain people can farm. Only certain people know how to garden. You have to go to a special institute that's very rarefied and hard to get into. And only those people can be allowed to farm. You couldn't possibly understand how complex, how difficult this is to farm. So you clearly don't have anything to add. And so now to a mantra. And next to the final slide. There we go. The beauty of my presentations being so spare is if the technology fails, I can always just give them off the top of my head. You may never know what that plant was meant to say. I could have said anything. But we're going to get to declaring a mantra. No equity, no value. Now that sounds a lot like another one. No justice, no peace. That's not by accident. I want us to think about this because surely people want to push back and say, well, you could have valuable things that without equity. Look at your liver transplant, Donna. That was high value, but not everybody gets one. But I want to dispel the myth that the value is in the thing itself, instead of in the impact that it has over people's lives. That the thing, without considering the context in which it sits, is what's important. We certainly learned in COVID that equity mattered, that if everybody didn't get a vaccination, it really didn't matter for anyone. When we think about cancer, we have fantastic treatments now in liver cancer. It just came back from the Society for Interventional Radiology and a meeting on immuno-oncology, but without early diagnosis, without being connected to care, people aren't getting those treatments. Those treatments have, in effect, no value. And when we think about things like CRISPR, surely you've cured the blind. That's like biblical level value, people. Why? How? You can't deny that. But if we create a genetic elite, what is the true value to a society for that? If we use cutting edge therapies, but don't take into account the fact that we have now changed the trajectory of that child's school or that family's life and employment, we're not really going to understand the value of that cure, of that miracle. And so I do say no equity, no value. They belong in the sentence, in the equation together. And finally, if we could have the last slide, the suspense is killing you. It's sort of like the Academy Awards last night. I mean, what's the envelope going to open up to? This. So it's not just my crazy thinking. It's been said for a very long time that injustice anywhere is a threat to justice everywhere. And we are caught in an inescapable network of mutuality, tied in a single garment of destiny. So said Dr. King in his letter from a Birmingham jail. We also note him to have said that injustice in healthcare is the most shocking and inhumane. Let's not forget. Thank you.
Thank you. Thank you, Donna. I have a couple of questions, but I don't want to monopolize. So I'm going to first open it up to anyone here in the room in Washington, and then also see if we have any online questions. Okay, while we're waiting, I'm going to ask you my top question, which is, what's your advice for patient advocacy organizations represented here today, patient advocates, for how they can play a role in advancing equity in health technology assessment, recognizing math is involved?
You know, I am called back to the lessons learned in the early days of HIV, where they sort of divided up the responsibilities and the skills that they needed to be effective in the space. So some learned about the science, some learned about some learned the math, some learned how to participate in conversations around value and reimbursement. So I think that the pressure to be all things across the space does not need to reside in any one advocate or any one advocacy organization, but it is important to make sure that someone in your therapeutic area, someone in your field is taking that on and is learning. I also think there's incredible value in working with situations where patients can be paired with researchers so that patients' experiences can be translated into the language of health technology assessment. And so that bridging function has also been very successful.
That's great. Thank you so much. Questions here in the room or any online?
My mother says that as a former federal prosecutor, I often speak as if I would brook no questions.
Well, so my husband jokes that I always ask the follow-up question, which must have not been a problem when we were dating, but now my 15-year-olds don't love it because they feel interrogated. So here's a follow-up question, Donna. Having reflected on the very impressive and important body of work that IVI has done in the equity arena and the report that was issued last week, is there anything that jumped out at you as something that you feel from your perspective as a patient advocate, as Global Liver Institute, that you really want to dive into, or that you want to or push IVI to double down on?
Well, I think improving the quality of the data is something that's very important. The representativeness through the process is the reason that we created our Advanced Advocacy Academy 5 years ago, so that there would be liver patients and caregivers who were trained for these various functions and could sit on these various committees and do this type of work. Because it's one thing to create a seat at the table, but if there's no one equipped to sit in it, that's as much of a problem. And so as an advocacy organization, preparing our advocates to be able to sit at the table has been important. And then as we look at the data, we've been doing two things. One is working to create new ICD-10 codes. We've done it in refinement in NASH, but we've also done it in a rare liver disease and worked with the Alagille syndrome, smaller advocacy organization to help their capacity to move that to being so that healthcare research, services research could be done. And I also think that we have been working to make sure that the as we look at and making this decision, the strategic decision about should we start our own registry or should we, Harlan Krumholtz insists that I need to have a registry, but having led PCORNet for over a year and seeing the value of being able to query multiple networks, multiple data repositories has really convinced me, and now I've convinced the advisory board for our Center for Liver Health Equity that we'll be adding positions in data science and data analysis to be able to sort of look for the liver data much more contextualized that we could do on our own, and really try to answer questions that matter to patients and families in that way.
That's great. It sounds like you're taking it upstream.
Yes.
To make sure that, to your point in your remarks about, we have to look at what we are shooting at in terms of our outcomes, and then we have to back up the
Yes.
methods and the data back upstream to make sure the object of our efforts is the focus and the intention.
I think the overall construction of our councils, which are constructed so that industry and clinicians and patients all sit at the table together, develop our agendas and questions together, is really, an essential part of how we function. And so we're much more likely, I feel, to have research questions, policy questions that reflect the fullness of our community rather than any one particular group.
I love that, crowdsourcing it and really making sure you have that 360 view. That's
Yes.
terrific. Yes, we have a question. Great.
Hi, my name is Stacey Cole, and I'm from Genentech. I loved your presentation, by the way. You're such a Rosetta Stone for connecting all these things that we do. I think you said, and very aptly, we are the converted, right? A lot of the individuals in this room already see the value of understanding equity or considering equity and are working on it. And my question, because I think you sound like you're great at working with lots of audiences, is what are the first one or two questions you would tell someone to ask if they wanted to think about this important intersection of equity and value? What are the things that you should tell, whether it's a researcher or whether a patient, what are the first few questions you think they should always ask?
I am very privileged to live with a research scientist for the past 19 years. Well, he even married me. So we discuss this frequently. How do you persuade someone who comes from a different perspective, a different background, a bit different training in terms of what's important and what the priorities are? I think understanding and being curious, staying curious, and asking why they think it won't add value. Why do they think it will slow the result down? What are they afraid of? What are they worried or concerned that would happen? Because it's wonderful whether you're looking at the information from the Clinical Trials Transformation Initiative or other groups. We've often been able to show that, in fact, the trial is not slowed down. In fact, the product is actually, even better accepted in journals. And so all of the things that are often very important to the scientific community or others who are reluctant have an answer in terms of belaying their concern or their fear, but really appreciating and honoring the fact that you want to have that candid conversation with them and really understand what they believe would be keeping them from integrating this work, and that you want to listen and respond is how you start.
Thank you.
Hi, Donna. Adrian Kielhorn from Alexion, the Rare Disease Division of AstraZeneca. Thank you for your very thoughtful presentation. I like the mantra. Patient-driven value is something we're trying to incorporate in our research. It involves talking to patients. My natural language is English. What's your experience capturing the patient experience using different languages? Because depending on where you are in the country, English may not be the language of choice when you engage with patients and let them talk about their personal experience.
So I speak at least 3 languages. I speak medical, legal, patient. and most of that is in English. All of our materials at the Global Liver Institute are translated into multiple languages. One of my proudest moments is getting a call from one of our scientists in Germany who said he wanted to talk about clinical trials with a family in Turkish. And so we sent Turkish materials to a German physician so he could talk about clinical trials in the language of his patients. We also have partnerships and organizations in multiple countries on at least five continents. And what we have found replicated again and again is the power of a patient and a committed clinician, or sometimes it's a nurse, sometimes it's a community health worker, from the community, sort of in language as well as in culture, who have the trust of the community and really focusing on eliciting what the patient or what that community finds important first before we dive in with our healthcare issues, and building that trust and that relationship. And then we have found a great eagerness to engage on issues. One of our most active groups is Friends Speaking in Cameroon, and they have done amazing things already, but it's because we didn't so much as come in as cultivate, and now we're able to add on all sorts of things that would be deemed super fancy. So
Thank you. I think we're at time. Please
Okay.
join me in thanking Donna for her remarks.